Good afternoon, everyone. Another edition of Newton-Wellesley Medical Group Lunch and Learn. We are proud to ask Dr. Sean Rocket to return to our hot seat, right, Sean? Talking to us about shoulder pain for the primary care provider. Next slide, Sean. We wanted to give a few intros and some teasing. Upcoming Lunch and Learns, we have Dr. Larry Friedman coming up on April 7th, talking about how I approach abnormal liver function tests. And then we have a talk about what a pain in the leg. And then, too quick for me there, thanks. And then school vacation week. And then next one is we're going to have Jordan Klicksman talking to us about an interesting sinus cases. So be on the lookout for those talks coming up on upcoming Thursdays. As you know, if you miss a talk, please take some time and look at the talks. They're all archived up on YouTube under Newton-Wellesley Medical Group Lunch and Learn. Just hit that in the search function. Also, we're on the intranet. Go ahead and look at under Newton and Education and Training. You'll see all our Lunch and Learns. Before we change slides, I also want to make sure folks are aware of two other learning opportunities from the comfort of your home or office. Of course, Dr. Friedman runs medical grand rounds every Wednesday morning at 8:30, and those talks are amazing. I think we had a great talk. I know we had a great talk yesterday on dialysis. So look for upcoming topics on every Wednesday morning at 8:30. And then we have our APP grand rounds, which is the second Tuesday of each month. And that should be coming up next month. We'll tease that towards the end of the month. Next slide. And then we wanted to say thank you for everyone who participated in Doctor's Day and came by and picked up a free water bottle and got a gift certificate for lunch or breakfast or dinner at our cafeteria. Water bottles are still available since we have a whole bunch of them, and we were kind of bowling with them yesterday because there were so many around still. Please contact Kathleen Servan to arrange to pick up your water bottle for yourself or your physician colleagues. So please, we bought them. We want to give them out. Please come by and grab that or have someone grab a couple for you. Thanks. Next slide. And then we also want to remind that folks that this is still going on through June 1st. Come and check out the Shipley Fitness Center for free. Can't complain that the hours are not reasonable because they open at 4:30, close at 10 o'clock, Monday to Friday. So plenty of time to fit in a half-hour workout. Saturday and Sunday also open 5 to 6. We ask that you fill out a health appraisal form, but otherwise, please, it's free. Come check it out. And if you were a paying member of Shipley Fitness Center, good for you. Your dues should have been frozen up until June 1st. Any questions, please contact Daniel Destin, the manager over at Shipley, and a great guy. And before we leave this slide, we want to make folks aware that we are organizing a softball team for an upcoming softball league, and we are looking for players. Daniel is the person to get in touch with for that. Please, you do not have to have any shoulder injuries, although Sean would be happy to take a look at your shoulder to pitch and play. But we are really looking for folks who want to have fun and get out there and start to reconnect with colleagues again. So please be on the lookout for that. If you have any skills or any interest, or you just want to come and hang out with us, please sign up for that. Next slide. And then, we wanted to make folks aware that we're still running this program, which we call Pay It Forward. This is where you as a physician recognize your fellow physicians for helping them provide best possible care. For instance, if I have a very difficult patient and I send him to this wonderful orthopedist named Sean Rocket, and he does something really great for the patient, and then the patient calls me and says, wow, Sean did a really great job for me, then I would recognize him and I would send him a card. And with that card, Sean, comes a $100 gift certificate for Amazon. And then what you would do, you would say, oh, wow. Sean would see a patient and say, wow, this other doctor has done a great job for this other patient. I'm going to send it to him. Therefore, you are paying it forward. And those cards go through our office, and we send really nice cards and software with a personalized note on it and a $100 gift certificate card. So if you have been a recipient of this gift card, please do not forget to pay it forward. And if you know someone who you'd like to pay it forward for, someone who's gone above and beyond for one of your patients, please contact Kathy Servan at the email above. Next slide.
John, can we just keep going back and forth, you and me?
We could. All right, I'll leave it up to you, Sean. Thanks again for being here, and we'll catch you up at the end for questions. There we go.
Great. Well, thank you. Thanks for having me. This is going to be a pretty bread and butter talk. You know, I'm not going to give you the esoterics of shoulder pain. I'm going to give you, you know, what you guys see in the office, and to try to help you make a diagnosis or just give people more information about it. And so this is the most important slide. This is our main phone number, the 617. And then if you have anybody that needs, you know, anything urgently, or you need to talk to a human being, our backline number is that number, 720-3600. So that'll get you. If you need something, somebody's really in pain, they need to be seen that day, give us a call, we'll get you in. So our group has expanded. It's Orthopedics New England, and I just wanted to go through, what we do, and we pretty much do everything orthopedic. And so that's me. There's Agam Shah, Arthur Cristiano. We're sort of shoulder knee specialists, and then we have all our PAs there on the right. And then we have Jay Salen, who's our hand surgeon, and we have Mark Fino and Kevin Sullivan, who do injections and epidurals and neck injections and back injections. And we have Mike Skanga, who does with Darren Bergman and Mark Rose. They're our foot ankle doctors. And we just hired David Ramsden, who does joint replacements, revision joint replacements, and anterior hips, as well as Ethan Healy, Dan Osuch, and then Simos Danikos at the bottom there is our spine surgeon. And Ethan Healy and Dan go to our offices. We have offices right in the Newton-Wellesley Blue Building. We have an office at Natick, and we have an office at Hopkinton also if anybody has patients out there. Anyway, so going on to the knowledgeable part of this, so shoulder pain. So when I see somebody, and this is really how I diagnose somebody, more on the diagnosis part and less on the treatment part, just because I think it's more important for you guys to be able to know when and what something is, and sort of give you an idea of when to refer and when not to refer. So categories are key in my mind. My first question, somebody comes in, the first thing I'm looking for is, did they have an injury or not? It sort of, that separates, and there's a slide, I'll go through the slides on this. It sort of separates my protocol, my decision-making. Are they young or old? It's unheard of for a young person below age, say 35, to have a rotator cuff tear. And I see a lot of people coming in and their therapists say they have a rotator cuff tear, and it's really unheard of for a young person to have a rotator cuff tear. Is it affecting their range of motion or not? So, basically, when I'm sitting in my chair, I can sometimes, I'd say 90% of the time, I can make a diagnosis just talking to somebody and seeing how they move. So is it affecting their range of motion? Can they do this? I'll just say, can you do that? Can you lift your arm up? If they can't and they had an injury, then, and they go like this, then maybe that's a huge rotator cuff tear. The other one is maybe it's a disc, a huge disc where they have shut off their muscles to their shoulder and they can't lift their arm up. And then the other one is, which is a tricky one, is frozen shoulder. Frozen shoulder is somebody's like, oh yeah, I can lift my arm up, and I go, can you get any higher? And they'll go, yeah, I can get higher. And they do this, and they do the tilt, the seated tilt sign. So what they're doing is they have a frozen shoulder where the joint is stuck and they're just moving their scapula. So they think they have a full range of motion, but they're actually stuck. And that's an easy diagnosis that you can make just by sitting and asking the person, can they go up like this? Can they go all the way behind their back? And then location of pain. Really try to pin somebody down and try to say, okay, where's your pain? And if they fell and they landed on the side of their shoulder and they go, I have a pain right up here, that's the AC joint. As you see up in the slide, the acromioclavicular joint, that's like the ankle sprain of the shoulder. If they say it's more in the front and more down here without any pain, I was just starting a weightlifting program and things are, I started lifting weights, doing push-ups. That's probably going to be a biceps tendonitis most likely. If they are older and they have pain down the side of their arm, that could be lateral, is usually, if you look on the slide, usually rotator cuff or bursitis. So, front is usually a biceps issue. It might be a little labral tear, or we call it a superior labral tear, which is part of the biceps, or a biceps tendonitis. A key topic or key point too is, does it radiate down into your, I'll show it, does it radiate down into your biceps muscle? If somebody says there's pain here, it radiates down in the biceps muscle, that's either a biceps tendonitis, or it could be what's called a slap tear, which is where the biceps attaches to the superior labrum up top. And then side of the pain is usually rotator cuff or bursitis. And then back, if it's in the back, that typically is more arthritis in an older person, and we'll see that on the x-ray. And then also if somebody has pain in the back and they are a young person and they fell and they landed on their arm like that, they landed on an outstretched arm with abduction like that, that can be an unstable shoulder because it hurts when the ball of the shoulder is riding forward and it pinches tissue in the back. So again, going into our categories, so injury, did they fall, did they land on it? Fracture, fracture is, you know, one of the first things that we think of. You know, so somebody comes in, they landed on their shoulder and they really can't move, or they have terrible, terrible pain lifting it. I would say that's a fracture. You know, so an x-ray would be good for that. And then the other, if the x-ray is normal and then they can't lift their arm up after a fall onto their arm and they're, say, over age 40 or 50, that would be probably a bicep, I'm sorry, a rotator cuff tear. If they have a biceps or a labral tear, if they have an injury, like when they fell or they grabbed onto something or they lifted something, imagine like the biceps contracting with some sudden lifting, that can be a biceps tear. If it's a full biceps tear, you'll get the Popeye deformity. You'll see the, and I have a picture coming up with that. And then if the difference between a labral tear and an AC joint sprain, typically an AC joint is a land on the side of their shoulder. So you want to ask them, how did you land? Did you land with your shoulder tucked at your side? And they'll say, I had pain here after I landed here. I have pain up here. Or did they land with an outstretched arm? And in a 40, 50-year-old, that could be a labral tear. And that could also lead to a dislocation. So some people will come in, they land like that, they dislocate their shoulder, and they get a labral tear in the front. So then you get into no injury category. So no injury is tendinitis. Did they start CrossFitting a month ago and started lifting weights and, increasing their weight lifting? Did they have something new or different? Something where they were, running. So I've seen running with tendinitis. Somebody is running and they're starting training for the marathon. They'll develop shoulder pain. I've seen that, believe it or not. Somebody on like a push-up challenge. They're doing 100 push-ups a day for the newest, for the month, and they'll develop a biceps tendinitis. So no tear, just pain, and pain tracking down in front of their shoulder. Bursitis, typically an older person with a bone spur, pain with overhead activity, pain with reaching up. Again, no injury, no, just sudden pain. Sometimes people have bursitis from sleeping. They sleep on the side of their arm. So I'll actually ask them about their sleep and try to have them maybe hug a body pillow, try to avoid, sleeping with their arm way up over their side. Arthritis, you'll see that on the x-ray, that if there's bad arthritis, somebody, has trouble moving, and that will be pain with moving without any injury. And then frozen shoulder, it's pretty common. I see a lot of frozen shoulder, and a lot of it gets missed. And a lot of it is just when you do the exam, or, the number one was ask them if they can lift their arm up over their head. And then the other one is, you got to hold their shoulder here. And then when you try to move their shoulder, keep their scapula from moving, prevent their scapula from moving. And if they're stuck in these positions with a normal x-ray, that's a frozen shoulder. And then another thing an x-ray will show you is a calcium deposit. So you can have calcific tendinitis, which the classic presentation for calcific tendinitis is god-awful pain, crying pain, all of a sudden, and they can't lift their arm because it hurts so much. And that's, if you get the x-ray and you see this calcium deposit, that's a bonus that you get to, make the diagnosis with that. But it's amazing. I'm surprised the amount of pain somebody has with a calcific tendinitis. And what happens is a little calcium piece breaks off and it creates a terrible, terrible bursitis to the point where you can't lift your arm up over your head, or even have somebody else try to lift it up over your head. Again, young, no injury tendinitis, really. Typically like softball pitchers, baseball pitchers, lacrosse players, they just, they've been in training all winter. They've been throwing it at home, throwing at the gyms they go to. No injury, typically a tendinitis. Injury in a young person, I would say fall onto the outstretched arm, as we talked about. That's typically a labral tear, which can accompany a shoulder subluxation or a shoulder dislocation. Falling onto the side, young person, typically AC sprain. So that's where you're going to ask them if they can point up there. Older person, no injury, bursitis, and then you go into the rotator cuff. And then, so the rotator cuff, you could have a partial tear. So here's my rotator cuff diagram. So here's the rotator cuff attaching to the humerus, lifting your arm up. And a complete tear is where the rotator cuff detaches. But it's very common to have a partial tear. What does that mean? It means in one area of the tendon, so you have, the rotator cuff, 4 tendons, but say you looked at just the supraspinatus up top, a partial tear is either like that, that's a partial tear, or like that, where a piece of it is like that. So you can have a small partial tear where a piece is just flipping around, or you could have a really significant partial tear. That means it's still attached, but there's all this tissue that is pulled away, and that can be painful. So that's what when you hear a partial tear. Slap tear, old person, no injury, slap tears of the biceps, where it comes right in the front. They have pain reaching up, they have pain reaching across their body, they have pain sleeping on their side at night. They can have clicking. So if you have clicking, that's a good sign for a new clicking and an asymmetric clicking. So you can have clicking. A lot of people can have clicking, but if it's asymmetric and painful, then that can be rotator cuff or a biceps tear or a slap tear. And then old, no injury, also, shoulder arthritis is something to think about. And then old with an injury, somebody's old and they fall and all of a sudden they can't lift their arm or it hurts to get their arm up, then you're thinking potentially rotator cuff or biceps tear. Range of motion. So I figured out, some people hear about frozen shoulder, they've seen it, but this is a case, if you look on the slide, a case of a pretty bad one. So forward flexion, I would call that to 90 degrees. Abduction on this side is 45 degrees. This side is 90 degrees. External rotation of 10 degrees versus 80 degrees. And then on internal rotation, we say, how high up can they reach on their back? So this is about L1, and this is to their buttock. If they came into here on the, their belt buckle, that'd be about L5 or so. So we say internal rotation to L1 or L5 or however high up they can get there. Fracture obviously will affect your range of motion, calcific tendinitis, and then nerve injury. If you have a really bad nerve injury, a huge disc herniation, you might have trouble getting your arm up, getting it up in front, or lifting something off to the side. So don't forget about the nerves and the muscle power that they supply. Range of motion not affected, but just pain reaching up overhead. Again, I would say more bursitis or tendinitis. And then if you have an abnormal x-ray, that's in your office, you're not going to see that, but so thinking about it, say they have the x-ray and then they come see you, abnormal fracture, obviously. And then there's the other thing. Sometimes fractures can be occult. An occult fracture is where you don't see a fracture on an x-ray. But if I examine the person and I'm suspicious of an occult fracture, which means that they really have trouble lifting their arm, moving their arm, you can have a fracture that is just seen on MRI. And then abnormal x-ray, you'll see shoulder arthritis. You'll see a grade 2 or a grade 3 AC joint sprain. So if here's the clavicle, a grade 2 or a 3, I'll come in. A grade 2 or a grade 3, it'll show up on the x-ray like that. A grade 1 will not, and that would be just a clinical exam. AC joint arthritis, you'll see 2 bones in here on the x-ray rubbing against each other. You can see the calcium deposit of calcific tendinitis, or even a loose body. And a loose body is pretty rare to have, but you'll see on the x-ray this little sort of marble floating around in the joint. So we always have people who give us a hassle when we say we want to get an x-ray of your shoulder, but there are, oftentimes it's very helpful to see an x-ray of the shoulder. X-ray is normal with shoulder pain. thinking, possible rotator cuff, labral tear, bursitis, tendinitis again. And then these are the easy ones. These are the ones where you just look at the person and you can make the diagnosis without even really talking to them. So you have the long head of the biceps. That is the classic Popeye deformity where the biceps is pulled down towards the elbow away from the shoulder. And then the pec. The left pec here is torn. You can see the left breast area is larger, and that is blood. That what happens is it fills with blood, and their pec area gets bigger. So it's sort of abnormal because it gets bigger. It's also retracted, so you see a little more fullness there. But what you see on the left side is you have this absence of the pec musculature compared to on the right. And you'll also have bruising if it's, say, more than 3 days old, I would say, is when you could see the bruising. And don't forget the neck. So this is a critical piece of people who have shoulder pain. Ask them where the pain is. And if the pain is in the back or up by the trapezius or back by the scapula, then I would say that's neck pain. If somebody comes in and says, I've had this shoulder pain, I say, where is it? And they'll point back here. That is typically a neck issue. And the way I check to see if it's a neck issue is to say it's on the right side. I'll say, tilt your head up. It's called the Sperling test. Tilt your head up and tilt it 45 degrees off to the right. And if that reproduces their pain back here, or their pain radiating down their arm, or that gives them tingling or pins and needles in their fingers by just doing what's called the Sperling test. So it's tilting up and just having them do it by themselves. And they'll go, oh yeah, that's my shoulder pain. And that is classically neck pain. So if you have pain and if you go from it's in the thoracic area too. These are referred pains. So you see the purple is C5, C6, and the yellow is C6, C7. If it's from the cervical or thoracic vertebrae over to the side of the scapula, if you have this strip of pain like back here, and you get it with neck pain, then that is with neck motion, I'm sorry, that is neck pain, typically, like a pinched nerve, a little cervical radiculopathy, a bone spur hitting the nerve, giving people pain radiating down the arm. So people, when they come in and they'll give you this mostly posterior pain, that is typically a neck issue, especially if it's associated with pins and needles into the thumb and index, or the middle finger, or the back. And if they can reproduce it when they tilt their neck, then I would say that is neck. So here's the gang again. I'm happy to answer questions if anybody has a weird case or an interesting case that they want to run by. This is our back number, phone number for everybody there, and then for you guys, for the primary cares, anybody that needs to get somebody in, please feel free to give us a call. We usually have enough people available to see people on the same day.
Thanks, Sean. So you guys take a minute and throw a case or a question into the chat box. Sean, one of the things that I struggle with, at least in the office, is the person who comes in, for their routine, and I'm sure a lot of PCPs get the same thing, and they've been saying they've been having shoulder pain for 6 to 8 months, and it's not affecting their daily lives. They're able to play golf or do whatever, but every time they lift a hand over their head, or in that older population, how do you manage those patients? Do you feel like that's mostly an arthritic kind of situation when they describe those kind of symptoms?
I'd say those people are more like, say it's an older person, say, 50, no. Say like 60.
Older. That can't be older.
Older in the big spectrum of things. 60 or 70-year-old who has that pain, I would get an x-ray to see if there is bad arthritis in their shoulder. And if it's annoying enough that it's been 6 or 8 months and it's affecting their sleep, first thing I would do would be, get an x-ray, but in the office, I would examine them. Do they have a full range of motion? I'd check their rotator cuff strength. If they say, oh, that hurts when I try to resist. And here's another little pearl that I've just recently. So when you test rotator cuff strength, we were always taught to check here at 45 degrees there. It was a more recent study that I read about, and I've actually correlated it at about 30 degrees. If you check at about 30 degrees, it's more, I think it's more sensitive for the most common rotator cuff, which is the supraspinatus. So checking somebody down here, and if they say, oh, that hurts, that could be a partial cuff or a full thickness cuff. And then the other issue is, you know, again, somebody who is just having shoulder pain. Number one is strengthening exercises. Those are pretty key. By the time I've seen people, they've already tried anti-inflammatory, so I don't go there mostly. A bursitis, one cortisone injection will take away the pain from bursitis. And a partial cuff, it might help with a cortisone. But typically I have a brochure from the American Academy of Orthopedic Surgery for shoulder exercises. I'll just give them the shoulder exercise. If they need to go to therapy or want to go to therapy, I'll have them go for a couple of visits. And then that's that's sort of the treatment options for that. If it gets, those things aren't helping, then bring them back, re-examine. And if I'm suspicious of a rotator cuff tear, then I would do an MRI. So.
And there's a question here about a cortisone shot in the chat as well. So, one of the things that, that always tends to happen is they get the cortisone or they don't get the cortisone. And let's say you give them the cortisone and it improves things. Is that more diagnostic, or that is what do you tell the folks after that? Do you tell them to go back and strengthening exercises, or what do you do typically?
Yeah. So so I can do a cortisone into the bursa in the back. I inject from the back. I'll feel the back of the acromion, and you go a centimeter below it, and you just aim. You aim directly, back here, and you aim up, and you go along the bottom of the acromion. And once you're below the acromion, you're in the bursa, and you're not in the tendon because it'll go easily. If you inject and it doesn't go easily, you're in the tendon, so you have to redirect your needle. But yeah, so a bursitis injection with cortisone is, I would say, very helpful. If it takes away the pain and the pain comes back, then I'd probably do an MRI looking for either a partial cuff or a full cuff.
And what about when we're examining these folks in the office and we see the shoulder pain, especially the acute shoulder? Are there things that we should be looking at as PCPs to say, oh gosh, this person needs to see Sean today, as opposed to this kind of urgent, semi-urgent kind of referrals when it comes to the shoulder issues at all? Is there some other pearls that you would give us? Of course, if we're worried about fracture, of course we would get X-ray. That's an easier thing.
Yeah.
But something else in that area that we'd be concerned about?
Like something urgent with the shoulder. If they're, obviously if they're dislocated or if there's a deformity, if they were a functioning person and all of a sudden they can't lift their arm, I would say something like that. A rotator cuff tear, which is massive and full thickness, you don't want to say go to therapy for 6 weeks. Somebody literally cannot, after a fall, can't lift their arm up. If you could have a small tear and that would be amenable to therapy, but if you literally can't lift your arm up and you're having trouble, I would say that person should be seen sooner than later. So
by range of motion, that's one of the things that we could use kind of as that goes.
Yeah.
Okay. All right,
but
great.
If they're moving and they're feeling good and it's just a little achy, then I would do exercises and things like that.
Excellent. All right. Well, thanks, Sean, for coming on, telling us about the shoulder. Sean's group is really, really accessible. They have 3 offices right on campus. Beautiful office in Natick, right by the mall. And then they have a smaller outpost in Hopkinton on West Main Street, if I remember correctly, right? Yep. Please give them a call if you need anything. Otherwise, everyone have a great weekend. We'll see you back here next Thursday. Don't forget to come down and pick up your water bottles. Contact us, and we'll go from there. Thanks again, Sean.
All right. Thanks, Sean. Take care. Bye-bye.